ดีค่ะยินดีต้อนรับทุกท่านนะคะกลับเข้าสู่ IAEA Expert Mission นะคะ Strengthening Optimization in Radiological Practice นะคะอาทิตย์นี้เป็นอาทิตย์ที่5แล้วนะคะเรามาเกือบถึงครึ่งทางแล้วนะคะทั้งหมดมี12อาทิตย์อาทิตย์นี้เป็นอาทิตย์ที่5นะคะแล้วก็เป็นอาทิตย์สุดท้ายของ CT Modality นะคะซึ่งเราจะมาพูดถึงในเรื่องของDual Energy Spectral CT นะคะแล้วก็ในเรื่องของ Cardiac CTA นะคะส่วนในเรื่องของ CT fluoroscopy เนี่ยเราจะไปพูดในเซสชันที่เป็นเรื่องของ interventional radiology นะคะซึ่งก็เช่นเคยนะคะเราก็ได้รับเกียรติจาก expert นะคะดร. L Brady นะคะจาก Cincinnati Children's Hospital เป็นหัวหน้านักฟิสิกส์นะคะที่ Cincinnati Children's Hospital ที่จะมาเล่าให้เราฟังถึงว่าจะมีในเรื่องของเทคนิคอะไรบ้างในการ optimization นะคะแล้วก็สามารถลดโดสให้คนไข้ได้นะคะ Good evening Sam Welcome to the lectures. Yeah. So this is a week 5 for the total of 12 weeks. So almost halfway that we doing the lecture series. And this week is last week for the CT modality. And we are going to talk about dual energy, spectral CT, and also cardiac CTA, which is a very difficult topic in my opinion because we need to get a good image quality in the small size of the cardiac vessels, and we need to compete with the heartbeat to get a good image quality. And most of the time, patients get a high radiation dose. So you're gonna teach us how to get a good imaging quality with the optimal radiation dose on the cardiac CTA. So, welcome.
Thank you. I'm glad to be back. So just like Tanya said, we're gonna try to finish off our CT module this week. I am just gonna get my screen. All right, now you should be able to see what I'm seeing. All right, so thank you Tanya for the introduction. So a little different this week. In the last couple of weeks, the first talk was focused on image quality, and then the second talk was focused on radiation dose optimization. But because we have two topics this week, for each talk, the first talk, I'm going to talk both image quality and dose optimization. And as Tanya mentioned, we're going to first start talking about dual energy CT, and then after the question and answer period for dual energy, we'll jump into the cardiac topic. So let's get into dual energy. Now let's talk image quality optimization. So from the very beginning, here we go. There we go. Sorry, it didn't want to work. So when you consider dual energy, what we're basically doing is we're going to scan the same tissue twice, but we're using two different energies of radiation, or two different X-ray energies, so two different KVs. And from the very beginning of the development of CT, Dr. Hounsfield always envisioned using two energies to scan the body, because he realized from the very beginning, all the way back in 1970 when CT was invented, that if you image two pieces of one tissue twice with two different energies, you can distinguish and identify the type of atomic energy or atomic mass of the image. And so if you know how it looks because of one energy of because you image with two different energies, you can identify, for example, the difference between iodine and calcium, just as an example. And so dual energy CT has actually been around for a very, very long time. The only reason we've only started using it now is because CT scanners weren't powerful enough back in the day, nor were the computers really capable of doing the reconstruction. So really, dual energy CT, as we know it, actually began in about 2006. And that was when the first of all the various different CT vendors introduced a CT scanner. Siemens was the first to introduce a dual energy CT scanner. So to understand how to optimize dual energy CT, we need to talk just one or two slides about fundamental physics. And so we all know, you've all been taught this in school, that the way we create an image using X-rays is the photon comes in and it will interact with the body. It'll either fully attenuate, and that's why the image looks, that tissue looks white, such as bone, or it might pass through the body and go straight to the detector, and therefore it'll look black, such as air or areas of lung tissue. And so what we're basically doing is we're measuring the attenuation effects as the radiation passes through each voxel or each part of our body. And radiation interacts with our body in one of three fundamental ways, either with Compton scatter, photoelectric effect, or coherent scatter. And we know that the radiation, as it interacts with our body, is energy dependent. So if you look along the bottom, along this x-axis, so you go from low energy to high energy, in this, in this area, from this purple line to the right, this is the CT range. So if you use 120 kV or an 80 kV, 80 kV would be on the low end, 120 kV obviously would be on the high end. And it just depends on the type of tissue. For example, here's muscle and cortical bone, and the energy as to which type of interaction the X-ray will undergo. So for muscle, as an example, if it's a relatively high energy, it's predominantly going to interact with Compton scatter, and there's going to be very little, if any, photoelectric effect. And conversely, when you look at cortical bone, if you're somewhere in the middle to low range, you're going to definitely have Compton scatter, but you might have a little bit more photoelectric effect. So why does this matter? Well, here I have the same phantom with various different inserts. And what I've done is we've scanned it with 140 kV and then similarly at 80 kV. And so you can see the color of the frame of each of these boxes. And I just roughly circled kind of where on this attenuation curve they would lie. So at 140 kV, basically we're only imaging this phantom using Compton scatter effects. But over here at 80 kV, you definitely have Compton scatter, but you get more photoelectric effect. And so when you look at these two images, the first thing you notice is at 140 kV, you probably can't distinguish the difference between the material of these two objects. But at 80 kV, they look different. So there's a reason they look different, because they're obviously different materials. So here I'm just simply going to reveal to you that it's an iodine plug at the top of this phantom and a calcium plug at the bottom. Now, until I told you that, you wouldn't know what the material is. But because this iodine, you can see here how iodine when the X-rays interact with iodine, it appeared differently at two different energies. Calcium is subtly different, but not as much. And this is the fundamental reason we can create an image with dual energy, is that each material will look slightly different at different energies. Now, you've probably noticed this effect if you've ever put an ROI in an image. So it's just a normal clinical image that we've created. And if it's, for example, bone, and we acquire it at, let's say, 120 kV, this red circle, well, that CT number is going to be a value. Let's say it's 900. Now, if we've imaged that exact same person or object, and we put the ROI in their bone, their CT number is going to be higher, much higher. It's going to be over 1,000 Hounsfield units. And so the idea that the CT numbers would change with different energies is that fundamental reason, because there are different attenuation coefficients for each of these tissues. And all of that is because we image with a polychromatic Bremsstrahlung radiation. Therefore, all of the X-rays exiting the X-ray tube have a very wide spectrum of energies, all the way from high energy down to low energy. We're not using monochromatic or a single vertical line, but polychromatic. And so therefore, each of these photons will interact with our body slightly differently. And you can see that depending if we image with 80 kV, which is this orange curve, versus blue at 140, there's different quantities of energies. So at 80 kV, there are more low energy X-rays, and blue curve, we're at a high kV, 140, there are more high energy kVs. And this is going to be very important, as we need a combination of both of those to distinguish the materials. So, as I mentioned, what we're going to do is we're going to acquire two images at the exact same location in the body at two different photon energies. So typically for the low energy, we're going to dial in about 70 or 80 kV. And that's what gives us, for example, this orange looking curve. And then for the high energy, we're going to be somewhere at 140 kV. And some of the newer scanners can even go up to 150. The whole thing, the main goal of dual energy CT by imaging at a low and a high kV is we're trying to separate these two spectrums as much as possible. So you want the high kV to have predominantly high energies and few low energies, and conversely, the low energy, more low energies and high energies. The areas where they overlap, the system cannot distinguish what that photon from the next. So if you get this energy, let's say 80 kV, you can see there are a fair amount of photons both at the 140 generated from the 140 kV and 100 kV, but the system has no way to distinguish the difference between the two of them. So what we want to do is we want to separate those two curves as much as possible. Now, the other aspect of this is it depends on the atomic number of the material we're trying to identify. And so what we're going to do here, as you see in this image of the neck, the thyroid is somewhat enhanced. And so it's going to have probably some iodine in it. And therefore, when we actually put ROIs in it and we image it at different energies, it's going to have a spectrum. It's going to be either not as bright, so more gray at the higher energies, but it's going to be much more intense or brighter, whiter at the lower energies. Now, the same could be said about the muscle, but muscle doesn't really infuse with iodine. So therefore, it's mostly going to stay the same iso gray color at all energies. And so if we're trying to distinguish the difference between a high atomic number, such as iodine infused tissue, and a low atomic number, such as just water equivalent soft tissue, we can do that really well because those two curves are very different. But that you see dual energy CT scanners that can identify the difference between muscle and say breast tissue or fat or lung is because this tissue is basically it all has the same atomic number. So what we're going to do in dual energy is we're going to look at very distinct atomic structures, such as an example, iodine and calcium. So what we can do is we can go in and we can take, if we want to create a reconstruction algorithm that will identify iodine and distinguish it from calcium, what we can do is we'll take a variety of different iodine concentration samples and we'll measure them first at 140 kV. And then we'll do the exact same thing. We'll image them at 80 kV. And as we do that, we plot along this curve a response curve for iodine at these two energies. And we do the same thing with calcium, and we can do it for multiple different tissue types and objects. And what we do is we create all of these various different curves. And the fact that these two curves are separated gives us the ability to distinguish the two. So once again, we can either go through and actually measure all of these tissue types or these various different concentrations of different materials, or you can actually go. Now, I don't know if the Thai government has something equivalent to what we have here in the U.S., but we have a website that it's the National Institute of Standards and Technology, and you can go on and they've already done all of this work. They've looked at how iodine, different concentrations of iodine at different energies, and they have all of the curves and all the tables. And so you can just take the numbers and put them into the CT scanner. And you can do this obviously for iodine, calcium, you can do it for gadolinium, you could do it for whatever you want to measure in the body, as long as there's enough of a difference. Now, what you need to understand is you need enough difference. Here you can see obviously this iodine is along this dashed line, calcium along this solid line. But the reality is every one of our CT scans, they are not perfectly noise free. And because there's a little bit of variation every time we acquire an image of someone, that means the CT number could be a little different. So there's a little bit of variation. And that's why you see this broad spectrum, this pink red spectrum here and this blue. And so you need to have these two lines separated just enough that we can take into account the uncertainty due to image noise in CT scanners. All right, so now we've been talking about what we need to do is we need a good separation between these two objects or these two materials so we can get a good clean separation, reconstruction, and then in that reconstruction we can tell which one is iodine and calcium. Now, the more separated these two spectrums are, the better the 80 kDV is on one side and the 140 is on the other side. As what that does is it shifts these curves farther away from each other. And so CT scanners that actually have a good way of separating these two curves will give us a much cleaner and more accurate calculation of what those different material types are in the body. And so once we have that, and we are basically going to go through and do some math, and I'm not going to go through all the explanation, but just simply what we're doing here is we have now two materials that we want to understand what they are, because we don't know what they are. We just know what their intensity is that we measure on our detector. And we've measured them at a low energy and a high energy. So we have two equations. So if you have two unknowns, you need, as you may recall from mathematics, you need two equations. And so we have that. And now what we can do is we can solve these equations for every voxel in our body, and we could create these sinograms specific for those materials that we're interested in understanding. So here I just give you a sinogram that is separated just for bone, and one is just for water. They're not perfect separations, and that's just because the material that the atomic structure of water, obviously water has hydrogen and oxygen. Well, bone is going to have some of that material in it too. Obviously, it's mostly calcium, but it's going to have some low atomic energy components to it. So there's never a perfect separation of all materials, but it's pretty good because they are atomic. Their effective atomic number is distinguished enough. Bone is real high, water, of course, is real low. We can still do a really good job identifying them. All right, so issues in dual energy CT that reduce material decomposition accuracy, or the ability for us to identify two distinct materials, is the overlapping beam spectrum. Another one is, as I kind of mentioned, image noise. So if we don't use enough photons to collect onto our detector, then there's going to be some uncertainty. Remember, there's that spread, that red and blue curve, there was that spread. And the image noise is much more prominent in lower kV images. And then, of course, there's always artifacts. One artifact that is very prominent, well, not prominent, that is detrimental in dual energy is the beam hardening artifact. And that is when, as you may recall from way back in graduate school or in medical school, when a photon enters the body, it's going to interact with that tissue. And so if you have a spectrum that is predominantly low energy, those lower energy photons are going to be mostly absorbed in the body, and only the higher energy component of that spectrum will exit and get on and collect onto the detector. And so it, quote unquote, hardens the beam. And so the beam shifts to a higher half value layer. And because the spectrum changes as it goes through our body, this is what causes beam hardening artifacts. Now, we want the distinction between one energy spectrum and another energy spectrum. But the thing is, we don't want those spectrums to be changing through our body. We want them to be mostly the same so that we can rely on the fact that we kind of know what an 80 kV spectrum looks like and a 140 kV spectrum. So we have to correct for that beam hardening effect. And then the final thing is scatter. Obviously, scatter is noise, in another way to say it. But you can actually have scatter effects that will affect the way we calculate dual energy. So these are the four fundamental things: overlapping beam spectrum, image noise, artifacts, and scatter, that we need to optimize when we use when we create dual energy CT. So Now that I've talked very broadly about the physics component of how we create or how we use two energies to create one image and use that to distinguish two different tissue types. Now you are, I think, primed, or you are a little better prepared to talk about all of the different CT scanners out on the market. Every vendor approaches their way they use dual energy differently. And because of that, you have to understand the pros and the cons to how they do it, because as I mentioned, there are 4 fundamental things we need to take into account, and each of them do it differently. Excuse me. So we're just going to go through all of the major vendors, CT scanners, and we're going to talk about the advantages and disadvantages as to how they create a dual energy CT scan. And then on the back side, after we've talked through all of that, we're going to talk about how to optimize the image. So first one is Siemens. They were the first to come to market to really attempt to make dual energy CT scanning something we can do for every patient in the clinic. And they decided to create a CT scanner with 2 X-ray tubes and obviously 2 detector rings. And so each of the tubes could operate independently. One could operate at a low energy and the other one could operate at a high energy. So this is going to fundamentally give you the best distinction of these 2 spectrums, because these two X-ray tubes can work they operate independently, and therefore it increases the quantitative accuracy of the dual energy image thanks to their better separation of these low and high energy spectrums. You also get really good noise control because you can independently increase the MA or decrease the MA per X-ray tube so that you get the right amount of signal at each detector without too much noise. So what are the limitations to a 2 X-ray tube or a dual source CT scanner? Well, the very first limitation is because there is finite space inside the gantry. You can kind of see here, one X-ray tube has a wider detector ring than the other one. And so tube A, for example, can image more of a patient than tube B. And so when you operate a Siemens CT scanner and you use dual energy, they always place a yellow circle over the body. And what that means is you can do dual energy inside this circle, but not on the outside. And that is just simply because that second X-ray detector is shorter than the first one. So there's a fundamental limitation to the field of view in which you can do dual energy. Of course, you can actually acquire an image that is what we call single energy or traditional image, but you will not be able to classify the tissue outside of that circle. Now, the other issue is scatter. If you have one X-ray tube and you get photons that come in here and interact with this body, well, those photons can actually scatter to the other detector. And so you have twice the amount of detectors, you obviously are going to have twice the opportunity for more scatter. And then finally, the fact of the matter is that the scanner itself, the X-ray tubes themselves are 90 degrees apart. In other words, as you image through this part of the body with this kV, and then you spin around and you image the other part of the body with a different kV, so one at, let's say 80 and another at 140, well, that's fine. But at one instant in time, this scanner will never image the same tissue with 2 X-ray energies. Now remember, fundamentally, all the way back to Dr. Hounsfield, 1973, the goal here is to image the same tissue twice. But at one instant in time, you're never going to be able to do that because the tubes are 90 degrees apart from each other. So there's what we call spatial temporal limitations. Obviously, they're very close to each other at 90 degrees. You only have to spin the tube a quarter of the way before you can image that same piece of tissue. But if you're doing something with, say, that's moving, such as your heart, obviously the heart has moved, so that therefore the tissues are just going to not be aligned. It can go really fast because 70 milliseconds is all it really takes to go from to go 90 degrees. But unfortunately, it's not perfect. All right, so GE and Canon. GE has done this from the beginning back in 2000, I believe, 12 or 2008 or 12, I think is when they came out with their first dual energy scanner. Canon only barely just changed over and decided to do what we call fast switching KV. So therefore, unless you have a brand new Canon CT scanner, they don't do this yet. So what this is you have one X-ray tube and one detector, but as it spins around the body, it is quickly changing from 80 to 140. It's quickly switching from low to high KV. And that is fine, but it just requires you to have it requires you to have a very fast acting CT generator, and you have to have very fast detector elements that can collect the signal and get that signal out to the computer, and they have to be able to do it very quick because in a small fraction of an angle, it's already collecting data from a different KV. One of the major advantages of this is because it's one X-ray tube, one detector, you have the full 50 centimeter field of view as an option. You're not limited like the Siemens dual source scanner. The system actually, most of the time when in normal CT without dual energy, the X-ray tube will move about 3 degrees between projections. So it has to go all the way around the body 360 degrees and collect all that data, but it's not actually collecting data every angle. It's collecting it about every 3 degrees. In dual energy, it's actually collecting it much faster. It's more of a fine sampling as it spins around the body. And so there's actually only about a 0.2 millisecond difference between the low image acquired in one angle, and then as it moves just a hair, it moves a half a degree, it acquires then the high energy. And so it's very quick. When we talk about fast switching, we're talking fast switching within 0.2 milliseconds. So that is very quick, 200 microseconds. And because it is very finely sampling over the body, the fact that we are almost imaging the same piece of the tissue with 2 different KVs simultaneously. This gets really close, but it's still not exactly imaging the same piece of tissue twice at 2 different KVs. It's a little better than the Siemens scanner, but it's not perfect yet. And so therefore, because of this, you get really good, accurate material identification or decomposition. And so basically what it does is because you collect at 80 kV and then you go you spin just a little bit and you collect 140 and you spin again at 80, you're actually missing, if you think about it, every other set of projection data, you're missing a little bit of data in between. And so to create a full, complete, and accurate image, it interpolates between these very close half a degree different projection data. And so there's a lot of interpolation at the low energy and the high energy, but it makes it very quantitatively accurate. And it's able to reduce all of those beam hardening artifacts because of how fine it's sampling over the body as it spins around the patient. So what are the limitations? Well, with the two source CT scanner in the Siemens, you can, as I said, operate the X-ray tubes independently. So you can put different filters in them and you can change the MA and the KV. And so you can really separate those spectrums. They're the best way to separate them is with the 2 tubes. There is also slight signal contamination. When you switch from 80 to 140, well, it's not perfect. It's not a perfect 80, then it turns off the 80, and then it goes to 140. And so that means sometimes as it spins from one half a degree to another half a degree, and it collects more data from the high energy as it goes from low to high, Well, there may still be a little bit of low energy data still in that detector element when you switch over and start collecting it at a high energy. So there's what we call just a slight amount of signal contamination, as it's not able to perfectly switch from low to high instantaneously. It gets close. As we say, 0.2 milliseconds, that's pretty darn good. But it's, once again, it's not perfect. And so because it's not perfect, there's a little bit of contamination between the low and the high. Well, it reduces your accuracy of exactly determining the distinction between the two. If these two material types, say calcium and iodine, are very far separated, well, that's okay. Your accuracy is going to be pretty distinct. But the closer they are together, then you'll have a little bit more problem. Being able to accurately identify what the material is. And of course, there's going to be more noise issues in the calculation of this, and that's just because as it spins around, as it spins around, it's doing its best to switch from one kV to the next, but it can't change both the kV and the MA at the same time, and so it's going to have some inherent limitations to how many photons it can produce at the low energy and the high energy. And remember, we said that noise is an issue in creating these images, and the noise is most problematic at the low energies. So we'll talk a little bit about that more when we get into the dose calculations. But because the other thing is the speed limitation, as it's spinning around and it's doing a very fine sampling around the body, the tube, it just can't go too fast or it'll not be able to sample as finely. And so there's a fundamental limitation. You can only go as fast as a half a second full rotation around the body, which is fine for most tissue types. But if you're imaging the heart, usually that's not fast enough. And so that means there'll be just when you collect the heart at 180 and then you switch to 140, well, the heart tissue, of course, will have moved, and so they won't be perfectly aligned in space. All right, so going on to the Philips scanner, they are distinct in that they basically put two detectors on top of each other, and then they put a little bit of a filter in between. So what's happening here is you're going to only acquire the image using 1 kV. 1 kV, either 120 or 140. But because low energies will absorb preferentially in the top layer, and only high energy photons from that spectrum will make it to the second detector, we are theoretically giving the detectors two different energies of photons. And that is just simply because we know some attenuate, the low energies attenuate in one, and higher energies are able to penetrate through. Once again, this is a single X-ray tube and single detector configuration, so you have full field of view capacity to image. And probably one of the best advantages to this approach is the fact you're using a single kV, say 120 or 140 kV. That means you can do normal single energy CT imaging, and then if you say, hey, I can't really see what I want to see, I wonder if dual energy will give me more information, you can simply reconstruct it with dual energy because that data is there. For the previous two CT scanners that we talked about, you have to, when the patient gets on the table, you have to pick the dual energy protocol. The system has to know from the beginning that it's going to image both at a low and a high energy. But in this one, it's always imaging at 1 energy, and it's just collecting 2 different spectrums based on its detector configuration. So that is one, I think, in my opinion, one of the greatest strengths of the Philips dual layer detectors is the fact that you can do dual energy CT on every patient, irrespective of you know a priori or beforehand if you even need that dual energy. And therefore, you don't need to build special protocols for dual energy. Everything is just inherently both single or dual energy. All right. This is the only time that you get perfect spatial temporal registration. Obviously, because the Siemens scanner has 2 90 degrees apart, they're never perfectly aligned. And the GE and Canon one, they're constantly switching, and so they're never perfectly aligned. But in this case, it's the same photon flux going through the body, always the same as it spins around the body. Therefore, it's perfectly registered spatially and temporally. And so it's really good for imaging and doing dual energy for something that's moving, such as the heart, or if you have injected contrast. It's not a small thing because blood is actually flowing in our body when we create an image of, say, the liver, and we want to look at it, I don't know, in the arterial phase. Well, blood is actually moving. And so if there's a subtle difference in time from one image to the next, low kV to high kV, well, they're going to be subtly different intensities. And so it introduces a little bit of uncertainty. Now, there was a study published back in 2017. And what they basically did is they took 118 patients and they performed them all just using the scanner. And what they basically said was, okay, we collected all the data, and then they said, okay, answer this question. Do you, after you look at the data, would you need more information? Would you use the dual energy information, or would you simply just stay with the single energy traditional looking image? And of those 118 patients, they ultimately felt, the doctors, the radiologists that did this, they felt that they needed more dual energy information than just the simple gray and white image. So 80% of those actually used the dual energy CT image data. But when you look at the patient history, only 20% of those patients would have been protocoled for a dual energy CT. So if these same 118 patients had been imaged on either the two previous scanners, then we would not have imaged 60% of them with the right. We would have left out 60% of the data, and the radiologist would have been just left with less information. So what that study demonstrated was that radiologists actually would prefer to have more information coming from dual energy consistently instead of the way we do it now, which is we simply protocol it based on patient history. All right, so because these are spatially temporally aligned or registered, it's very quantitatively accurate with fewer artifacts, and the noise in the images it has very, very low noise in these images. We haven't talked about the monoenergetic the monoenergetic or mono E images yet, and we will. But one of the advantages of reconstructing with dual energy is obviously you can determine which material is which, calcium, iodine. But we can also create different looking images. We can create really high contrasty, low mono E images, and we can create low contrast, but low noise. So let me start over. High contrast, which tends to be high noise, and low contrast, but tends to be noise free. That is true for everyone except for Philips. Philips, it basically has no noise in all of those images. And you'll see some examples later of patient data where when imaged on a different scanner, these lower effective energy, these low mono E images are really noisy, but they have a much more intense contrast. You can see this stent right here. It is much more intense. And as you can just imagine throughout the entire body, wherever there was iodine or bone, it would just be more intense. Limitation is because you're actually using 1 kV and you're artificially trying to separate it. There is a lot of overlap when you look at the two detectors and their spectrums. And so because of that, there is a penalty to the amount, the types of tissues you can differentiate. All right. The next one is the traditional Canon scanner. So if you have a Canon scanner now that's more than a couple years old, this is how you would do a dual energy. Basically what it is it will spin over the body twice. So once again, you're able to image with 1 kV, and then it switches and it goes over the exact same location a second time. And so this is fundamentally what Dr. Hounsfield said. Same tissue, imaged at 2 kVs. The way it does this is actually at a very, very low pitch. So the body is constantly but slowly moving through the gantry, and the system is just spinning. And it's every time it goes around the body, it changes from low to high to low to high to low to high. And so every tissue type gets imaged twice. Because of this, you get nice noise characterization. The limitation, obviously, is that it takes the amount of time for it to spin all the way around, to switch kV to spin back all the way around. And so if you're imaging something that's fast moving, such as heart or blood that's transfused or perfusing through the body with the iodine in it, those moving objects are not going to be spatially temporally registered. And so you'll see just artifacts, and you'll see misregistration in the image. And then finally, in somewhat the same way, a patient with low pitch, very slowly moving through the body, through the scanner. Well, this Siemens system came out, and they basically put a very specialized filter on the end of the X-ray tube. Most bow tie filters, almost all bow tie filters, are primarily aluminum. They may have some other materials there to help it, but mostly they're aluminum. And so this one, it took half of the filter and used tin, and the other half, it put a teeny layer of gold on it. And because these two materials, in addition to aluminum, are there, they each have different attenuation profiles. They basically split the beam. And so as photons pass through this side, they'll have one energy spectrum. And as they pass through this side, they'll have a completely different energy spectrum, high versus low. And that's great. And so basically you can take this filter and stick it in any X-ray tube. It's a single tube, single detector. So you're imaging with 1 kV, and you're imaging with the full 50 centimeter field of view. It doesn't take very special scanners. There are no limitations on how slow or how fast you can rotate, so it's all nice. The biggest limitation to this, once again, obviously, is it's slowly passing through, the body is slowly passing through the CT scanner, so nothing is perfectly registered, spatially temporally. There can be scatter effects from the low to high side of the filter as it goes through the body and onto the detector. And because gold and tin they have different attenuation. Gold is actually a very highly attenuating material, as so is tin, but they attenuate slightly differently. That means you actually have to turn the MA up real high, so you get really high photon flux coming through. Now, all of those photons aren't actually hitting the body, because a lot of them are being absorbed in the filter. And therefore, the system is just fundamentally limited on how big a patient it can image. If you have a really big obese patient, then this system will not be able to provide the right amount of photons coming out of the X-ray tube. Now, last week, someone asked if we could talk about Hitachi. And similarly, the question would be, what about the other scanners? Do they also do dual energy CT? So Shimadzu, Hitachi, United Imaging from China. These are wonderful CT scanners in their own right. And I went out and I actually spent a couple of hours. I was digging and digging and digging, trying to find all the information I can on these 3 scanners. These are not very typical here in the US. You probably see them a little bit more over in the Indochina, Asia area. That said, they all said they can do dual energy imaging, but there's really nothing in the literature. So unfortunately, I couldn't really give you a lot of information about these 3 scanners. My guess is they all have similar either fast switching or spin-spin acquisition types for dual energy. So not a lot that I can report, but I think that's actually a great invitation for you all. If you go out here in the US and you try to publish papers on Philips and a Siemens scanner, there's actually a lot of publications out there. So it's harder to publish that data. A lot of people know about those scanners and how they react and work for patients. You guys actually would do a great service to the scientific community if you have a Shimadzu, Hitachi, or a UI image CT scanner, and you were interested in developing the dual energy capacity of those scanners. Publish that information and get it out into the literature, And people like us over here in the US or, in the West, that would actually be very helpful for us. And so I just say that's an invitation to you. Unfortunately, I cannot give you more information. I just could not find it in the literature. Now I'm sure there's some out there, and I didn't read every journal, but I did spend quite a few hours going through using Google and looking for the PubMed and all the various different publication avenues. And I just was unsuccessful. So my apologies. I know there was a request to have some Hitachi data. All right. So we've talked about the fundamental physics of how to create the image. We talked about the 4 fundamental things we need to optimize. And then we talked about how each CT vendor has a different approach to creating dual energy. So it is incredibly complex, this process of using dual energy. Obviously, there's 4 things we need to optimize, but you have to know which scanner you're using and how it acquires the images so we can actually optimize those 4 things. But before we get into that, let's talk a little bit more broadly. What does dual energy provide? If we understand kind of what we're trying to get, the information we're trying to get out of the image, then we kind of know a little bit what we need to do, how to create the image, and how to optimize these 4 things. So the first thing is it was the first thing I think that they developed dual energy for, which was the differentiation of uric and non-uric acid stones. And here you can see an example of an acquisition, and it's a dual energy. You can see it was a Siemens scanner. You see that yellow line telling you this is dual energy in here and no dual energy out here. So obviously it's got to pretty darn important to get your kidneys inside that, in this case, get inside that circle, or you won't be able to differentiate the stone itself. Distinguishing between the two is very easy. Well, I would say very easy. It's highly accurate. But differentiating the different types of non-uric acid stones is still kind of a work in progress. The problem is when you look at these various different types of non-uric acid stones, they all basically have the same effective atomic number. And therefore, they basically have the same attenuation pattern. So when it comes to this stone identification, we're really looking at the difference between, is it uric or non-uric? In other words, will you have relapse issues? And it just depends on how you triage the patient for treatment. And I know you know that, you're the radiologist. Another thing is gout. So looking at, kind of inflammation, arthritis type issues, gout, it can be characterized by the uric acid crystals versus pseudo gout, which is be characterized by more of a calcium buildup. And so, once again, you got the distinct difference between these 2 objects and their atomic numbers and their attenuation profiles. And so when you image the body, you can very easily identify and color code here what a uric acid would look like here shown in green versus calcium or a pseudo gout shown in purple. Just another example, as I was looking through some of the publications, this is an MRI on the left and a woman that has been going through breast cancer. She had a lumpectomy and a larger, actually a mastectomy. And so they placed in a silicone breast implant, and they were looking for extracapillary silicone leakage. So it's very obvious in an MRI, but in a CT, a plain CT, it wouldn't be as obvious. Dual energy, of course, silicone versus soft tissue is highly differentiable. So it's something we can distinguish very quickly, just as an example. What else can we do? Well, if you have 2 distinct objects with 2 distinct atomic numbers, you can quite literally subtract one of those out of the reconstructed image. So you can do bone subtraction, you can do iodine subtraction, and get what we call a virtual non-contrast image. So instead of doing a 2-phase liver study or a 2-phase abdominal study, where you image without the contrast, then inject them and image them again, in this case, you can inject them with the iodine contrast, image them, and then physically subtract the iodine out of the image and get this virtual non-contrast. And then, as I've been demonstrating through and talking about this, if the materials are distinct enough, we can actually identify them, and so therefore we can color code it. So if you're looking at, calcium versus iodine, or uric versus non-uric, you can actually create these pseudo color plots and demonstrate that as an overlay to the actual grayscale reconstructed image. Because of the way the image is acquired using both low and high energy, and because artifacts are different at the low energy KVs and the high energy KV, we can more readily identify beam hardening artifacts and other types of artifacts in dual energy, and not very easily once again, but more appropriately reduce those energies, those artifacts in the image. So you can actually do pretty good, in this case, metal artifact suppression in what's called single energy. All the vendors have this option, but it's not perfect. You see the residual effects. But with dual energy, you can see how it almost completely gets rid of all of that streaking and beam hardening artifact. So dual energy can be pretty artifact free when you calculate, when you develop it right or reconstruct it right. And then finally, we talked a little about creating what are called monoenergetic maps. Basically what that is you take the low energy spectrum images data and the high energy data and you blend them together. If you use more low energy information to reconstruct the image, you'll have a lower mono E. And if you use more of the high energy to create and a little bit of the low, you'll have a higher mono E image. And the obvious that you see here when you look from low to high is the lower energy mono E images have very strong contrast. Obviously, this is a contrast diffused image. The kidneys are just as bright as can be. The liver and spleen are much brighter. And you can even see the vasculature. But as I mentioned, for most vendors, with Philips being the only one with the exception, because it's a lower energy, you have a lot more image noise. And so sometimes it can be harder to read through these images. But if you look at the higher energy, you lose your contrast. The liver and the spleen are almost look iso dense in the grayscale, but it's much cleaner. And so this is one of the benefits where, in my opinion, identification of uric and non-uric in pediatrics is really not that big of a deal. And hopefully we're not really dealing with gout with kids. Some may do have arthritis issues, but for the most part, those tend to be usages or protocols that we would create for adults. And so oftentimes as a pediatric physicist, everyone asks me, well, what do you use dual energy for in kids? I tell them this is probably one of the most important, this is one of the main reasons why I would use dual energy in kids is the fact that you can get 5 or 6 or 7 different views or looks or different types of ways to look at that child's image, but for the price of just one image. And so if you are trying to look at a high contrast image, but you also think, it's too noisy, so you can just simply dial it back and you can look at a less noisy image, or if you want to keep dialing it. So instead of, you can window and level in it using your mouse, right? You can window and level, it goes gray, and it changes the grayscale. In this case, you can also shift it left to right, and you can change the contrast effect in the image. So it's actually very powerful. There's just a lot of information. In a monoenergetic image, the 70 kV, which is basically in the middle, is equivalent to a 120 kV image. So in a single energy CT scan, our traditional 120 kV acquired image, if you look at the 70 kV, they're mostly comparable. Now, with this ability to physically look at an image and make it look more contrasty and less contrasty, one of the other benefits to this is we do not need as much IV contrast when we do dual energy CT. And so for someone that might have renal functional impairment, but you still want to do an IV and do an iodine contrast enhanced CT, well, that's fine. Maybe you can dial back the amount. You can dilute the concentration, or just simply, obviously just use less IV. And then you can still, so if you would normally do that in a single energy CT scan, it might look more like this, or it might look more like this over at the high energy. And as a radiologist, you can't see the vasculature, and it's subpar, it's a suboptimal image. But if it's dual energy, all you have to do is just dial to a lower effective, a lower mono E, and boom, there's your vasculature. So that's one of the probably more, that's one of the benefits, obviously for adults if they have renal impairment, but also for kids too. All right, so how do we accurately interpret material subtracted images? Well, first, let's talk about some misconceptions. The first one is, if we're going to measure, so if we look at an image with iodine concentration mapped onto it, if you draw an ROI on it, it's not actually it's not going to tell you the exact concentration of the iodine in that location. So you might be looking for iodine uptake in, say, a tumor, or some kind of lesion. It's not perfectly, if the ROI wouldn't tell you the exact concentration of iodine, because obviously the iodine is mixed in with the blood. So you just have to remember, just because you see the iodine and it's very intense, that doesn't necessarily mean it's a perfect and one-to-one correlation of the actual concentration of that material in the body. Also, because these virtual non-contrast image, when you're physically subtracting out the iodine component, all voxels in the image are a mixture of different materials. And so, for example, the liver itself, when you infuse it with iodine, every voxel is going to have some soft tissue in it, might even have some fatty uptake in it locally, and it'll have iodine. And so when you reconstruct it, the appearance of it is a combination of all of those atomic numbers, all of those materials in one. And so if you simply subtract one out, well, it's obviously going to look different. Well, apparently you get rid of the contrast, so it's a virtual non-contrast image. But you're also taking some of the information away. So if you put an ROI on any one of the tissues and you want to look at the CT number, well, the CT number is going to be inherently different than it would be if you acquired the image a true non-contrast single energy CT. Therefore, the fats, the muscles, the CT numbers themselves are going to be subtly different in a virtual non-contrast image acquired with dual energy than they would with a single energy true non-contrast image. And so, looking a little bit further into that, a publication by Mahmoud that came out in 2018, is they looked at, I can't remember, 100 or more, a couple hundred patients. And what they did is they looked at the true unenhanced images. So this column right here, this first column, these are patients that were imaged without any IV contrast on board. So what would be considered a true unenhanced image. Then in the center here, these are patients that were imaged with dual energy. And so these patients had contrast on board and they were acquired with contrast, but then we mathematically subtracted it and this is called the virtual non-contrast. And then we have different ways. Once we've identified which tissue, if we remember those two curves, if we're trying to identify iodine as one of those curves and maybe, soft tissue or water as another curve, well, what we can do is we can do a plot where we simply just look at the plot where it's got the density of water, or we could do the density of iodine. So it's subtly different than the virtual non-contrast. I'm not going to really get into the difference of it, but there's just a different way of looking at the image without iodine in it. Just a different way of reconstructing it. So in this case, they looked at a couple of different things. Hemorrhagic cysts down here at the bottom. They looked at hypodense lesions and then focal fat in the liver. And what you see in the true unenhanced, you see the cyst, you see the hypodense lesion and the focal fat here. But for the virtual non-contrast and the material density maps, the cysts are you can't see them, and it's arguable that you can't see the hypo here. It's maybe there, but maybe not. And then the focal fat is not present too. So it's not always perfectly true that you can just subtract. Like I said, when you subtract out the iodine, you're also fundamentally changing the way the image looks when you reconstruct it. Now, the one caveat to this, and they mentioned this in their publication, was when they acquired the dual energy images and then did the virtual non-contrast, they actually acquired it in an arterial phase. So potentially, and some other people have published this and have said that it's potentially possible that had they done a portal venous phase and then did the subtraction of the virtual non-contrast, subtracted the iodine, that maybe these hypodense and maybe the cystic hemorrhagic cyst would appear. So this goes to show you that when we're optimizing and creating dual energy protocols, not only do we have to figure out which KVs we're using and how much radiation we're using to create the image, we also have to figure out what the timing is. Do we use the dual energy at the arterial phase, the portal venous, the delayed? Do we acquire them all three? All of this information needs to come into it because there are some clinical issues that may not be apparent in one or the other options. And so there's still a lot of information we don't understand exactly how we use and protocol for dual energy. All right, so when we consider the monoenergetic images, if you look at the 70 kV mono E, remember that's the most similar to a true quote unquote 120 kV image. If you look at them, in a different actually in that same publication with Mahmoud, the radiologists looked at them and they were asked to consider the vascularity. How conspicuous is it? Was it sharp? Was it well defined, etc.? And so when they looked at the water iodine maps and then the iodine overlay map, so it's a nice grayscale image, but the system has identified what is iodine and what is water, and it does a pseudo color over the iodine area. Basically, every radiologist said they preferred the water images right here, the iodine images where you subtract the water information out and or you simply do a pseudo coloring over top of the vasculature. And that, in their case, made the vascularity of the image appear more conspicuous and just more intense to the eye and is more pleasing. So monoenergetic imaging is also very beneficial if you want to make something stand out a little better in the image. So let's talk a little bit about how do we optimize dual energy CT protocols. Attenuation really needs to be paid to the very low KV setting. Of the two spectrums we're going to acquire, let's look at the low KV setting. Low KV settings have the most, that's where most of the noise is found. So the noise is most prominent, most intense, which we've seen. That's where most of the artifacts are found. And then the quantification accuracy is the most difficult at the low KV settings. So how do we handle image noise in dual energy CT? Well, we can actually use different reconstruction techniques. We can use iterative reconstruction, which is standard on all CT scanners now. And therefore, we can both clean up the low energy and the high KV images. Where it's possible, there's been many publications out there demonstrating different types of reconstruction. And if your vendor has those types of reconstructions, algorithms, you should use those. So that's one of those things you'll just have to, depending on if you're Siemens, Canon, Hitachi, whoever you own, whichever scanner you own, you need to then just ask them what their different types of reconstruction algorithms are available. If you're just using the same filter back projection or iterative reconstruction, you may realize that there is actually something else out there that's better. Now, when you go to set the right amount of noise in the image, you may ask yourself, well, how do I do that? I've got two energies, and how do I optimize the noise in both of these energies? Well, luckily, the CT scanner does most of this. The vendors, before they even sold you the scanner, they did a lot of research and they built a lot of different algorithms in the background. So what you typically do is you'll sit up and you'll decide what type of noise I would want in a traditional 120 kV single energy CT, just a normal looking image that you would acquire every day if you didn't have dual energy. How much noise can you tolerate? And you will establish that noise target value. Now, remember from last week, all vendors have different noise indices. GE calls them noise index, Canon calls it SD, Siemens, Philips, Hitachi. They all have their own way of defining the noise. So you would set that for each of those independent vendors the way you normally would do it. And then the system will calculate what that volume CTDI would be for that noise index. And then the system, when you turn on the dual energy, will then optimize the right amount of MA for the low and the high setting, doing its best to match that same volume CTDI. And so it's doing its best to try to keep the dose, quote unquote, output the same between the two spectrums. Now, the resulting noise then would be the 70 keV mono E image should be similar to 120 kV single energy CT. So once you've done that, you've set your noise index and you've set up your protocol. If you image, for example, a phantom or something, what you want to immediately do is look at your 70 keV mono E image and compare it to an image that you acquire with 120 kV single energy. If the noises are the same, then you've actually optimized it appropriately. So how do we maximize the accuracy, the quantification accuracy? Well, this is actually something that we've kind of talked about throughout this whole process, establishing diagnostic reference levels. You need to have a good understanding of the CT scanner, its strengths and its weaknesses. And to do this, you need a robust quality control QC program. And one way to do that is to get a phantom and to scan that phantom. And this phantom has to have multiple sensitometry inserts. So this Phantom Lab phantom you can buy, it has one of these cylindrical rings that has a variety of different material types inserted in it. The Gamix Phantom has the same thing. You can actually pull these out and change the configuration, which you cannot do with the Phantom Lab. You can even add your own. The Phantom that I have, I can put water inserts, or I can get ones with a variety of different iodine or calcium inserts. And the CIRS Phantom is very much like the Gamix Phantom. It's various different inserts. You can change the location of it. The difference is their Phantom is more quote unquote anthropomorphic. It's more oval, whereas this Gamix is just a big circle. It's a big cylinder. And so by imaging these phantoms on your scanner and doing it over time, you'd establish the reproducibility of your CT scanner, but you're also able to help establish the right noise levels and all of that. And so having these phantoms are actually a very good first step for a good quality program. So just in summary, what are the benefits of multi-energy? Well, we've talked about better differentiation and being able to identify the different types of materials in the image. So material decomposition or characterization or identification is kind of what we're trying to do. We want to improve the appearance of artifacts. And so dual energy CT actually removes a lot of these artifacts from the image. So they're mostly artifact free. And then better visualization of tissue contrast. And this is that idea where you can change the mono E so you get really good, intense, contrasty images versus noise-free images at the high end of the spectrum. You can, as we discussed, potentially reduce the amount of iodine IV that we inject into the body. It's just much better for our kidneys. Now, for the last few minutes of the talk, we're going to talk about the radiation dose optimization aspects of it. So just really briefly, let's talk about all of those major vendors again. So what is the advantage of using a Siemens dual source CT scanner? Because each X-ray tube operates independently, you can use the right MA for the low energy and the right MA for the high energy spectrum. And so you can manage the noise really well. And if you have a very big patient, you can penetrate them perfectly fine. You can use tube current modulation. So as it spins around, you can change the amount of MA you use for the thicker part versus the thinner part of the body. And obviously, I meant to delete that, but basically you're still limited with the field of view. All right, advantages for the fast switching is that the noise and dose, because it makes very fine changes as it switches around, as it spins around the body, very finely sampled. You can optimize the noise and dose very finely as it goes around the body. Now, you will spend a greater amount of time acquiring low energy. So it's not always perfectly maybe low, high, low, high. It might be low, low, high. The system will change the amount of times it uses low versus high, depending on how thick or thin the patient is. So it cannot do, the limitation is it cannot do tube current modulation in the sense that as we are, thicker through our shoulders, less thick through our chest, we don't need as much photons, MA through our lungs, and then our abdomen, of course, and our pelvis, we need more. It cannot change the MA as it goes down longitudinally through our body. And it therefore will it will set the MA to generate the right amount of noise in the low energy KV images. Now you might say, well, that's wasted photons at the high energy. So every time it acquires KV, 140 KV image, but at an MA that's optimized for 80, well, you're correct. That is just a waste of MA. You don't need it. But you have to do that because it can do a very quick switch between low and high KV, but it can't do a low switch MA. It can't switch the MA and then it cannot switch the KV and then switch the MA, switch the KV and switch the MA. It's very difficult doing that. So as the CT scanning technology improves, maybe one day they will be able to do that. All right, so one of the advantages of the dual layer is the fact that you can once again acquire the images like you would normally in a single energy. So you have tube current modulation. And then the advantages for the slow switching are that as it spins around, obviously you can change and modulate the MA very easily. So you have tube current modulation in that respect. And you can get the right MA for the right KV. And then advantages for the slow switching is that it's able to balance the right amount of MA as it goes through the body, has it basically tube current modulation. But we mentioned the major limitation for this is the photon flux. It's very hard to get the right amount of photons through these really thick filters, and so you really can't do very large, very obese patients. So what kind of doses are we talking about in dual energy? Well, historically, a decade or decade and a half ago when we started doing this, dual energy CT was much higher dose than single energy. And so it was immediately developed for adults, almost never used in kids. And for the most part, we said that because there is more information in dual energy, improved CNR, improved material specification, therefore we can justify using higher amounts of radiation in patients just because we're getting more information. Now, with the advances in the dual energy CT technology, the most modern CT scanners, the radiation dose output for dual energy is basically the same as single energy. So I went through and I read a bunch of papers. And one of the things I tried to do is I went back and I just kind of went 6 or so years back, and I started to look, 2015, 2016, 2017, how did the dose spectrums change as we move forward in time? And so as of about 2015, you can see here the dual energy, the volume CTDIs are listed here compared to the low dose single energy CTs. And you can see they're basically the same. When you look at all 35, the aggregates average was identical. In 2017, a paper out of the Journal of European Radiology, a older second generation dual energy CT scanner was still slightly higher in dose than the single energy. It was about 10% higher. But then in that same publication, they looked at a third generation, which was the most advanced dual source CT scanner they had. And the single energy was actually higher than the dual energy. The dual energy represented a 15% reduction to patients. In 2018, that Mahmoud paper I talked about, the single energy versus the dual energy was about 35% lower. And then in 2019, looking at these second generation dual energy CT scanners, there was about a 28% reduction. And then the third generation was an 8% reduction. So now a couple of things to point out was from 2017 with the second generation, where the dose is actually higher for the dual energy. Sorry, won't go forward. You can see here after just a couple of years of fine tuning and optimizing the protocols, now even on these older dual energy CT scanners, we can get, I wrote those backwards. You can actually get dual energy now that's a little bit lower dose. My apologies. The dual energy is actually a little bit lower. At least I think it is. My apologies. I think I may have written that down wrong, but we'll just ignore that for now. But the third generation, the nice thing is look, we went from third generation where we were imaging at roughly 5 to 6 millisieverts. Now we're imaging at about 1.5 millisieverts. So even though the dose reduction wasn't as distinct going from single energy to dual energy, when you compare just going back a couple of years, so just 3 to 4 years, the new dual energy CT scanners are about 50 to 90% lower in dose compared to where they were just 5 years ago. So the overall dose reduction has come down. We are using radiation much more optimally and very little when it comes to dual energy. Now, when it comes to actually comparing the image quality, for example, looking at the 70 kV mono E images compared to a single energy 120 kV, you can see 25% reduction in radiation dose, and in this publication, 25% reduction in IV contrast. So you can maybe leverage that. Instead of doing all dose reduction, you can do contrast reduction too. And then finally, in another paper where they looked at what kind of dose reduction can you get when you're thinking about a clinical task, in this case, uric versus non-uric acid stones. In this case, dual energy CT, because those two objects pop out. The stone, obviously you see the stone in a single energy. Everyone can see stones because they're just little white dots in there. But being able to not only see the white dot, but determine if it's non-uric or uric acid based, you just don't need a lot of radiation. And so because of the additional diagnostic information, in this paper back in as far back as 2016, and this paper as far back as 2012, they had already reduced the radiation dose substantially by 50 to 75%, and still were able to have the same diagnostic task, able to answer the same diagnostic task. So the most advanced dual energy CT scanners are basically dose neutral, and at times they are lower dose than single energy CT scanners. Now, the older model scanners, at least the ones that I wrote down right, I hope, are maybe a little bit higher dose than the single energy CT, but we're still learning to optimize those, even though they're an older model scanner. Obviously, dual energy provides an enhancement of image quality, so you get a much greater contrast to noise ratio, and you get much more diagnostic information. Therefore, in the cases where maybe the dual energy CT is just a little higher in dose than the single energy, one may argue still the benefit to risk ratio is much more tilted towards the benefit side. And then modern DECT protocols are highly optimized can be highly optimized for best patient dose experience. In other words, it's no longer just one dose for every patient. We're using tube current modulation. We're being able to adjust it for the size of the patient. So they've become much smarter scanners. Now, looking out and into literature, I could not find any diagnostic reference levels for dual energy CT. It's my understanding that even in Thailand, that's not something that you've approached yet. But that's the same in America, it's the same in Europe, it's the same everywhere else. And so this is a great opportunity that as Thailand now starts to install their dose tracking software throughout the country, maybe at probably the larger academic centers, you're probably going to do maybe more dual energy than your community centers. But as you start to collect this data on how you're using dual energy, and then how much radiation you're using in those scanners and the types of scanners you're using, you'll be able to then obviously establish your DRLs. But you'll also be able to look at the greater, broader image in all of Thailand as to how best to approach image quality and more specifically dose optimization for dual energy CT. All right, that's that. I went a little over. My apologies, Tanya.
That's good. Thank you so much, Sam, for giving us the overview about dual energy and spectral CT. And it's always an excellent talk from you about this aspect. So, what do you think about the future direction of the CT? I mean, in next 5 or 10 years, we're gonna have our hospital going to have dual energy or spectral CT, or do we?
In the US, there are some hospitals now that do all dual energy. It is probably going to be. So the one thing I did not talk about is because it's still mostly academic is photon counting. And that's where, kind of like in nuclear medicine, we physically count how many photons come out of the body and collect in the gamma cameras and the PET scanners. We know exactly how many photons come out. Therefore, we can reconstruct the image specifically knowing how many photons are here and how many photons are here. We don't do that in CT. We just dump. It's like taking a big bucket of water and you just dump it on your head. It's hard to count how much water got your hair wet. In CT, it's just we can't count all those photons because we use so many photons. But in these newer CT scanners, we can actually, the detectors are fast enough, we can count how many photons we collect in every detector element. That's called photon counting CT. Mm-hmm. Photon counting CT is kind of the next future of where CT will be. Probably not for another 10 or more years. Excuse me, but photon counting is inherently the same as dual energy. Because we can count the amount of photons, we can also count or calculate the energy of the photon as it strikes the detector. So instead of doing dual energy, 1 energy and 2 energy, in photon counting, you actually you calculate all of the energies on that spectrum. And so dual energy CT is kind of actually it's the stopgap. We go from single energy to dual energy. And once we figure out dual energy, when photon energy comes in, that's going to revolutionize all of the way we do CT imaging. So yes, I think that we will all eventually move towards dual energy CT imaging.
No, the reason I'm asking because right now we start collecting the data for the single energy, like the conventional machine. And then if in the next 5 or 10 years, our hospital or the trend of the CT going to be dual energy or spectral CT, so maybe we should start thinking, collect the data right now to have to prep ourselves to be ready for the future.
The answer is yes. I mean, this is more in the future. So for what you guys are doing right now with the diagnostic reference levels in Thailand, you're collecting most of your information for single energy CT or traditional CT. But in the institutions in Thailand that do use dual energy, that would be very important to collect that data, because there will come a point, maybe in the next 5 years or so, where you will see more and more use of dual energy. Right now, we're still trying to figure out clinically what are the practical applications of dual energy. Stones, gout, these are things that are actually helpful diagnostically. But would you go buy a really expensive $2-3 million CT scanner to just image stones? I'm sure your hospital administrator would laugh at you, because you can do that with a single energy CT scanner. And so what we really need to do is develop the clinical application of dual energy outside of these, stones, uric acid, etc. Is there a room in oncology for dual energy? Is there a room in cardiology for dual energy? Et cetera, et cetera, et cetera. And that hasn't quite been developed. So as we develop those two clinical questions, that's when you'll see dual energy used almost always. And that's where, as you start collecting all of this dose data, it'll be very helpful because you'll already have some levels of data so you can set your DRLs in Thailand.
Yes. So we also have Dr. Panrutai to help us with the discussion sessions. And, do you want to ask something, Pan? Or?
I believe that in university hospitals in Thailand use dual energy CT. There's just starting the idea about the CTPA, and indeed the two hospitals trying to do the survey for the dual energy in CTPA, but probably about within these 2 weeks, we will have the number.
That's awesome. That's wonderful.
But if it is possible and no problem with the collecting the data, we will spread about this Excel file for collecting data, but just only one about the CTPA.
Okay. Yeah. And that's especially when it comes to diagnostic reference levels. You don't actually set a diagnostic reference level for every protocol you have in the hospital. Obviously, it's just there's too many. And so for example, you'll pick the top 10 most used protocols, and that's the ones that you send out to all the hospitals in Thailand. And so dual energy is one of those things where, like as Dr. Panutai mentioned, is we're only doing a few of those in a few select academic centers. But as those academic centers publish their data and they go off and they teach and train, I think you'll see, like you talk about the CTPAs, that protocol might actually get used a little bit more universally in Thailand. And so having that data that's a great thing to have those dose values.
And may I ask about you said the dose from dual energy and single energy are about the same. So in pediatric patients, if in the larger children that we use 120 kV, and if we choose to do the dual energy, is that common in the US in the children's hospital or not? If we can make the dose not higher, and how about the image?
Yeah. And so that is the question that we've been trying to answer here in the US and in Europe too, all around the world is there a reason to do dual energy in children? 5 to 10 years ago, the answer was no, because the dose was much higher. It's 2, sometimes 3 times as high as the single energy CT. And so no one really looked at it. But now, as you mentioned, the doses are about the same, especially for the larger kids. If you were going to image a teenager at 120 kV, and if you flipped it over and acquired that image in dual energy, the dose would probably be about the same if you're using one of the newer CT scanners. If you're still using a scanner that's maybe 5 or 10 years old, the dual energy output would probably still be higher. So that said, assuming the doses are neutral, why would we do dual energy in kids? Clinically, there's really not there's not a what we call a silver bullet. There's not really that one indication that makes a lot of sense. When you look at a kid with a kidney stone, if it's uric acid or non-uric acid, does that change the treatment? And at our hospital, it doesn't. And I'm sure it's the same through most hospitals. We just treat them all basically the same. And that's okay. That's fine. But as I mentioned, I think one of the strengths in dual energy CT, especially for pediatrics, but it's the same for adults, are the ability to do the come on. it stopped moving. There we go. To being able to look at the same image, the same patient, a variety of different ways. And so looking at these monoenergetic images, if sometimes kids can be difficult. And so let's say we injected the IV, but we missed. Let's say we missed the portal venous phase. As a radiologist, you're looking over at the hepatic arteries and you can't see the hepatic arteries. That's a problem, right? But instead of going back and say, okay, let's repeat the image, but this time let's make sure we get our timing better. Instead, what you could do is you could just simply look at your 50 keV or your 60 keV, and then you can compare that to your quote unquote traditional 70 keV image, which is what it would look like in single energy. And hopefully, there you go. Maybe you can see the hepatic arteries and maybe the vasculature is there. So this is the one area I think for pediatrics, it makes the most sense. Is A, we could maybe dial down the amount of contrast that we use and we inject, and we could just have more information for you, the radiologist, to look at. Obviously, you're all busy. You're already looking at hundreds of images in single energy. Do you want to look at another 400 or 500 images in multi-energy? That's something we have to figure out.
I think that in the case that we cannot get the intravenous access, that is very good, and can like a slow flow injection or something.
Yeah. Yep. And so, yeah, but to be honest, here in the US, we do not do a lot of dual energy in kids. We just don't. And we're still looking for that. The doctors, the hospitals are still looking for that clinical indication that makes a lot of sense for dual energy. So hopefully we'll get there one day.
And I think there's some question from the audience.
Okay. Let's see.
So there is a question about the difference between monoenergetic and monochromatic images. So can you explain the difference on those things in depth to clarify the clinical useful of these two definitions?
Sure. Yes. And so looking at this slide, what you see on my screen, when we collect the data in the low energy, let's say 80 kV, and the high energy, 140 kV. So as it's either spun around twice or we had our two tubes, however we collected the data, we now have data for hopefully every slice in the body at 2 energies. And what we simply can do to create these quote unquote monoenergetic maps is we just take a little bit of the low and we take a little bit of the high spectrum and we blend them together. If we have a lot more low, then the image will look like the lower monoenergetic maps. And so obviously, when you image a patient with a monochromatic or a single energy scan at, let's say, 80 kV, the image just looks much more intense. We talked about it last week, how you actually have to set your window and level differently, where the radiologist will look at the image and they'll get blown away. It's like looking into a light bulb. So the monoenergetic maps are simply just a ratio or a way to take the data from both spectrums and combine them in a unique way so that you can look at either high contrast or low contrast. Much more noisy images in the contrasty image, but less noisy at the high end, but lower to no contrast. If you want to compare what all of these monoenergetic images would look like if we collected them in the single energy, that is why I keep referring to the 70 keV. This one is the quote unquote closest looking image to what a monochromatic or single energy image would look like. In fact, if you actually put the two side by side, which I think, oh, come on. No, actually, I don't think I have that. I don't think I have that data. But if you actually compared a true 120 kV image to a 70 keV image, the 70 keV image actually would look a little less noisy and have a little less artifact. And that's why, like I said, there are some hospitals that are moving all of their imaging to dual energy here in the US. And it's just because these monochromatic images actually they can look a lot nicer. So I hope that makes a little more sense.
You mean like a mono E is just a low KV image, but monochromatic is like some cross processing and mix some stuff to get a good signal to noise ratio on that low KV.
So and I may have said the word. So in all my talking, I may have said something that may have been confusing. So monoenergetic images are mathematical calculations of all of taking the low energy and high energy and blending them together. If we had the ability to image with just one energy, one monochromatic image, photon, if we had somehow the ability to only image with 40 keV photons, then that's what the image would look like. But what we're trying to do is we're mimicking that by taking a little of the low energy and a little of the high energy and mathematically calculating it. So, I mean, they'd be subtly different, but that's just how it is. So a true monochromatic image would look like each one of these images, but we don't do that. I mean, there is such things as synchrotron radiation, and we can image with that, but that's just not what we do in the clinic. It's academic. We don't even think about that. And so the closest thing we can get to monochromatic imaging is breast imaging, and that's just because we have really low energy with the different filters. So don't get too caught up on the fact that we call these monoenergetic maps. They are meant to be like a monochromatic image, but they're not actually truly monochromatic. So the distinction is purely mathematical. So let's just put it that way. It's purely mathematical.
Yeah. So the next question, I think you already answered. So the next question is, when we do the weighted average or blended processing images in the clinical procedure, what is the theory behind this kind of images? So I think you already answered.
Yeah, by blending them just gives you a little bit more of the contrast versus a less of the noise. And that's just what you see on the screen. It's just how many different monoenergetic images you can create.
Next question is about the Philips system. So does the second lower layer of the detector get any artifacts from the upper layer of the detector?
Yes, there is cross-contamination. They do put a filter in between to try to prevent that. But is it perfect that you get exactly only the low energies at the top and the high energies at the bottom? And the answer is no. Maybe I should have probably put a picture on here of a spectrum. So this is a dual source CT where the low energy spectrum and the high energy spectrum are pretty far separated. In a Philips system, they're very overlapped. And that's just simply because you're actually only using 1 kV to create the image, and you are trying to separate the two by doing some really cool physics. I have to admit, it's really neat the way they do it. And let's be honest here for a second. If I put a dual energy Siemens scanner and a dual energy image from a Philips scanner and a dual energy image of a GE scanner, and I put those 3 up, and I didn't tell you which one they were, I probably should have done this. Could you tell me the difference? Probably not. So we talked about all of the advantages and all of the disadvantages of each of the systems. And that is simply because when it comes to setting the right noise and the right dose, each system is slightly different. And who does that matter the most to? The physicist and the technologist. They're the ones that have to get the right numbers in the right place. And when they do that, then they present the images. You remember our optimization team. They present the images to the radiologist, and the radiologists say, oh, too noisy, not noisy enough, too much contrast, not noisy. And then you guys work as a team to get the right image. But when it's all said and done with, if you buy a Philips scanner versus a Siemens scanner, I think you would be perfectly happy with the dual energy. There are some differences. We talked about them. But for the mostly clinical day-to-day application, I honestly don't think you would see a big difference. So yes, there is a contamination, and yes, it does affect the true calculation of the difference between, say, iodine and calcium or iodine and water. But visually, could you probably see it? In my personal opinion, no.
So like a final product for the clinical use is the same. It's just the process to get those images and make technologists happy when they use the scanner.
Yeah, and it's like I said, they each have their benefits. I mean, the dual source CT scanner really does great job with the dose. You can, we showed you in some of the slides all the way in. They're only maybe 1 or 2 millisieverts. I mean, 1.5 millisieverts. That's great. That is so low. That's about a factor of 10 lower than it was a couple of years ago. The Philips scanners and the Siemens and the GE scanners and the CAN scanners, they may not be as optimized because they don't have 2 independent tubes, but the overall image quality is still basically the same.
So the last question, I think this is very interesting. The question is, in bi-tubes, dual energy CT, only a part of the images has dual energetic information due to the small field of view of one of the 2 tubes. Do we need to pay more attention when positioning the patients than a single energy CT?
Yes, the answer is yes. So we talked about last week how, where do you put the patient? We should put the patient in the center of the gantry, right? The reason for that is because the bow tie filter is a very specific shape. If we put the patient in a different place in the gantry, it can enhance artifacts. It can enhance the dose to the patient, all of these things. But that said, if you want to know what the dual energy is over here in the ribs, you got to get the ribs inside that circle. So this is that one fundamental limitation. Now, that is true to this scanner. And they have changed a little bit. The newest scanner, the 3rd generation, you can do 35.6 centimeters, which may still be kind of small for a large patient. They previously were, I think, 28 or 29. The 2 systems are actually not 90 degrees. The 2 extra tubes are not actually 90 degrees. They're actually 95 degrees. They kind of opened it up just a little bit so they could make the second tube detector a little longer. But yeah, if this is the scanner you have and you need to see dual energy somewhere outside of that circle, when you go through, you put the patient on the table and you create the localizer image. So you're looking at their topogram or their scout image. It will tell you where on that image you will see dual energy. And so then you, as the technologist, have to know, I might have to actually physically shift the patient, and so that you can get the dual energy in the right location.
And which means it can increase dose location?
It can.
Right.
It's hard to say. It's hard to say just because every patient's a different size. But it's really, when it's all said and done with, is it going to change it a lot? Probably not. It's going to change it a little, but not a lot. And if you really want that diagnostic information from dual energy, then is just a little bit extra radiation worth it? The answer is yes. Up to this point, people have been using dual energy for the last 10 plus 10, 15 years, and they always said they would justify the extra radiation dose because look at all the extra information we're getting. If that extra information is vital for the clinical answer or the clinical task, then yes, the radiation dose is worth it.
Okay, sounds good. So which means that we need to communicate between like a technologist and a radiologist, and we should let them know that the field of view does not include the area of interest. Let's say liver cancer, and I mean based on these images, the liver, we did not include the whole liver for the dual energy. So which means if the radiologist need the information from dual energy on that liver cancer, we need to move the field of view, adjust the center of the patients, and maybe increase a little bit radiation dose, but it's like a communication things that we need to do.
Yep, it is. And so, like I said, it really depends on the type of scanner you get. If you are someone that thinks dual energy is really the future, but you don't quite know how you're going to use dual energy on every one of your patients, then this scanner is probably not the best scanner to have. It might be the Philips scanner. This one. Because this one, you can do dual energy on every patient, and you can just turn it on and off whenever you want. If you do know exactly why you're going to use dual energy, but your patient population is larger, then this might be the scanner you need. And so I'm not saying one scanner. I'm not pro Siemens. I'm not pro GE. I'm not pro Hitachi. I've never used Hitachi.
Vendor neutral.
Yeah, I'm very neutral. But you have to look at the pros and cons of every scanner and look at your population, your patient population, and then you'll make the right decision.